So, besides that, ICPerMed has worked on the best practice. We also have had a track on medicine policy, and there were a couple of nominations, and we will now today listen to two of them. And the first one coming up now is the Canadian path from discovery to implementation of personalized medicine approaches. And the two speakers are Etienne from the Canadian Institute of Health Research and Catalina Lopez-Correa from Genome, British Columbia in Vancouver, I suppose. Yeah, so please.
Okay, so thank you very much for the kind introductions, and thank you also for having selected our abstracts. We're really happy to be able to present you a little bit of our kind of mini Europe model that we have in Canada with the federal government and the provinces. So that's why me and Catalina will be sharing actually this presentation. So I'm delighted to be standing here because we've been involved since 2012 in our personalized medicine initiatives, and we started already at that time to be involved with European activities by being part of the CSA-PerMed, actually even the application of the CSA-PerMed. So at that time we launched the Personalized Medicine Initiative, and really one highlight of this initiative from our perspective is really the numbers of partners that we were able to bring to that initiative. And the most important one being Genome Canada, and I think Genome Canada and the regional genome centers like Genome BC, they've been incredible partners into that. But in addition to that, there's many more competition and application partners coming from various domains, including patients' organizations, which have also been instrumental into developing our approaches and bringing that lens in. In parallel to that, there was also an e-health innovation initiative that was launched, again, trying to gather as many partners as possible. These were mostly application partners, so instead of partnering on the overall competition, being kind of forced or highly encouraged to be part of the applications with the research team, to be able to bring some members of the industry and this type of expertise in the applications received. So both applications kind of came naturally together, and in 2016 we launched the Personalized Health Initiative. And building on really all the early encouraging aspects and the discovery projects that were funded, this initiative really aimed to look at the implementation into the healthcare system, and also to look at all the how this could be done in a cost-effective manner to bring sustainable healthcare. And also the last bullet here, it's not something that I've added for this conference, it's really something that I have like ongoing on my slide. The alignment with ICPerMed was from the get-go a core component of that initiative, because in 2016 we had moved from the CSA-PerMed now to ICPerMed, and in parallel to that embedded the international component with ERA-PerMed that I won't talk more about it because Raphael will be talking about that in length subsequently. So one of the flagship programs that we have had in the Personalized Medicine Initiative was the 2012 large-scale research applied research project competition that we co-led with Genome Canada. This certainly has been a very successful program with rather large investments, at least from a Canadian perspective. Also requiring matching outside sources, which could be at that point, again, patients' organizations were there, pharma was there, some provincial funding mechanisms were also involved. So 17 projects were funded, and one key characteristic of these 17 projects, and most importantly the 15 research projects that were funded, is that all the projects had the requirement to integrate what we call GELs, or the genomics, ethical, environmental, economic, legal, and social components within the project. So, and in the review criteria of the calls that we set out, this was really a core component of the review, and something that the reviewers really needed to make sure that it was meaningfully integrated, I hate that word, but that were really well integrated into the research proposal, and which with the aim of really encouraging and facilitating the translation of the projects into actual healthcare eventually. And there's also 2 standalone GELS projects looking at how to improve the development of personalized medicine approaches. And Catalina will talk more about how the genome centers like Genome BC really work hard to make sure that these got well integrated. So out of this, I will present 3 examples that came out of this competition. The first one is the iChange program, looking at childhood astrocytomas, so very invasive brain tumors, having devastating effects on the children. And starting doing very discovery projects, they were able to, and looking at the epigenetics of these and the driver mutations causing these tumors, they were able to identify a driving mutation, and that's now part of the World Health Organization test recommendation, and to develop a very simple genetic test that is easy to implement in routine diagnosis, and that is now standard care in many countries. And that's actually based on that simple test, they are able to change the first-line treatment that they're trying for these patients. The second one is more on rare diseases. It's the Care for Rare project. Well, maybe just going back to the iChange, one thing that made that project really successful is that they were able to network, to create an international network collecting samples of these brain tumors. And this is really a key features of many of our projects. I think the sociology of the Canadian researchers make that it's really easy for them to actually establish this network. And this is also a feature of the second one here, that they were able to unite pretty much all the clinical geneticists in Canada identifying rare disease mutations. And in addition to that, and well, identifying many novel disease-causing genes and all of that interesting aspects, but also to contribute significantly through activities like the activities of the Global Alliance for Genomics and Health to the development of data sharing and normalization, which allows now through the matchmaker exchange and based on their own database, the phenotypes that they've developed, to share some phenotypic and genotypic data around the world. So the data does not actually move, but through API database are able to connect and to find potential matches when to try to identify the causative genes of rare diseases in pediatric patients. The last one, and for that I must say that François Rousseau is here in the room, so he would be much more in a much better position to talk about it, but we're really happy about the Pegasus project as well. So that one looked at the use of non-invasive prenatal testing to actually try to identify aneuploidy in expecting mothers as a second-tier test. So instead of using amniocentesis, which causes stress to the fetus, which leads unfortunately to premature termination of pregnancy, using non-invasive prenatal testing is a really easy way to just collect blood of the mother and to achieve the same scientific outcome. But this project, in addition to seeing how this could be implemented as a genetic test in a public system, and in the standard laboratories, they also looked at the health economics of it and were able to demonstrate that this was at least, that was cost neutral, at least in the Quebec healthcare system. So cost neutral and actually prevent some negative outcomes of the amniocentesis. And in addition to that, they also integrated the ethical aspects by looking at the ethical, social, and legal implications of implementing the new the NIPT in Canada. And even prior to the official release of their results, they've been asked by Quebec government to sit on the panel that were evaluating whether or not that would be something that should be implemented in Canada. And it is now implemented in Quebec. Well, I should have said Quebec. Another example here, and I'm going to go through this one here, which is quite interesting because this is kind of a dating service between clinical geneticists identifying new novel disease-causing genes and biomedical researchers having animal model. So instead of the classical from bench to bedside, then it's the from bedside to bench. And this is kind of with ongoing application, it allows to give some small seed grants to model organism researchers to start studying in novel genes that just got identified in patients. So you can see here a quick statistic and a little bit their website. Again, something done in partnership with Genome Canada and Genome British Columbia. This is the example of paper that come out of that, but more than the paper, it's really the knowledge here, which using zebrafish, introducing the same mutation that was identified in patient, you are able to recreate the developmental problem that is seen in the patient. And after that, using some compound that you add into the water of the zebrafish tank, in this case, salicylic acid, you can revert partly the phenotype, which leads quickly to the potential identification of therapies or potential therapeutic targets that could be used in patients. So, as I said, we started with a foundation showing early signs of implementation, but really the demonstration of the value of personalized medicine was in infancy when we launched the personalized medicine initiatives. Many biomarkers or clinical data were not used. So with that, we decided to launch this second wave, and Catalina will talk a little bit more about that. In that complex ecosystem here, regrouping patients, researchers, industry, the federal government, but also province and territories. Now, the big question is how bold do we want to be? And I think that many of the talks here have been very stimulating for that. We are really looking forward to try to develop that ecosystem where we integrate multiple sources of data here, including, well, genomics, of course, but all other type of data to transform data into information by also working on the diagnostic, predictive, and behavioral analytics. And finally, translate that into knowledge, so being able to translate that to the clinicians and patients and citizens. And also looping it back to research, which is really the biggest value that we can find, I think, in personalized medicine. Now I'm going to hand that to Catalina.
Perfect, thank you. Well, thank you, Etienne. That's a good introduction. So I think it is important for me to first explain a little bit how we work in Canada. So Etienne is Canadian Institute for Health Research. It's a funding agency based in Ottawa. And we have the Genomic Enterprise, as we call it, that has Genome Canada in Ottawa and has a genome center in each of the provinces. And that's important for health in particular, because the way we will think, okay, Canada is just one country, is a universal healthcare system, so implementing genomic and precision health should be easy. Well, similar to Europe. We are not just one region, we are many different provinces, and each of the provinces has a different policy and way of managing the healthcare system, reimbursement system, and also approval for new technologies. So it's a very complex system, much more than what we think when we think about Canada. And the fact that we have all these genome centers in each of the provinces is really helping getting us closer to implementation and closer to have this dialogue in policy and reimbursement and all that. Now, we at Genome BC have been, as all the genome centers, in operation since the year 2000, so 18 years, and a lot of investments have been already made in genomics and precision health. We have actually about 145 projects that have been invested, and we have projects in all the continuum. Projects that are focusing in prevention, projects that are focusing in using genomics for diagnosis, treatment, prognosis, and that's why we're not talking about precision medicine, but we're talking about precision health, because we want to include prevention, and we want to make sure that it's not about just the disease, but it's about even not entering the system, just keeping people outside of the hospital and outside of the healthcare system. Now, as Etienne said, there was a competition in 2012, and there was now a new competition in 2016. So for us at Genome BC, we basically, again, we have an interesting model. We collaborate with the other centers, but we also compete with the other centers for funding. We want to attract to every province all the money we can to build a larger infrastructure and groups in genomics. So we did the competition in 2017. Etienne talked about the one in 2012, and the projects he showcased were projects that were funded in 2012. Now we had a new competition in 2017, and there were 15 projects funded. BC was very happy. We're the smallest province with the smallest constituency in health, and yet we had a big success in this competition. We had 6 out of 15 projects that were led by BC scientists, and 2 where scientists from BC were co-leaders. Our target for this competition, for every competition, we have a target of the percentage of the money that we want to attract to the province. Our target for this competition was 25%, based on the population, based on our previous success rate. And guess what? We got 38.5. So we were extremely happy to get all this. That represents about $80 million that will be coming to BC to support genomics and precision health. Now, here is a little bit of a snapshot of the projects that we got through that competition, and you will see that they are in very different areas. We have projects in pharmacogenomics, we have projects in leukemia, we have projects with First Nations. We haven't talked much these days here about the need to increase diversity, equity, and access. Well, this project called Silent Genomes is getting a high profile in Canada because it's our way to connect with the First Nations remote regions and increase the reach of genomics into more isolated regions. We have a project with genetic counselors. We have a project on microbiome. So basically a very diverse portfolio, and you see that those projects go, each of them, from around $4 million to $10 million per project. So it's a significant investment, and hopefully those projects will help us advance the implementation of precision health. Now, one important point, as Etienne mentioned, each of those projects has to have, is evaluated based in 3 criteria. And we in the centers are helping the teams get the projects, really good quality projects on those 3 areas. So the science has to be good, and basically always the science, we have strong scientists, so the science is the, I would say, the easy part. Then the projects have to, each of them have to demonstrate the socioeconomic benefits for the province and for Canada. And they have to really make a case. It's not about saying, oh yeah, we will have potentially a project. They have to give numbers. They have to make a real economic case about the potential impact that project will have. And that's always a challenge. And it has to be always embedded. So each of those projects had the business case and the economic case built as part of the project. And each of those projects also has to have a GELS component that Etienne mentioned, which is all the ethical, legal, social, and environmental aspects of genomics. So each of them had a research project inside the research project that will talk about either the ethical, the legal, the social aspects. So I would think that when we compare to maybe other large-scale projects around the world, I think Canada, that's one of the differentiators for Canada, that always they have these components, the economic benefits, the GELS, and the science, all together in each of the projects. Now, for BC in particular, we have been going through an exercise on what is the key priorities for the province, and we came out, as many others, with these low-hanging fruits, where we think we will have a faster implementation in the clinic, and that's infectious diseases, rare diseases, cancer, pharmacogenomics. And we think infectious diseases, rare diseases, and cancer are growing in an incremental way. We are already doing that. We are already implementing genomics. We are already having some projects on those areas. What we see could be the real transformation for BC, in particular for our province, is pharmacogenomics. And in particular, pharmacogenomics in primary care with family doctors. And that's where we're trying to do a larger implementation that's going to be, for us, transformational, not just incremental. We started with one project that we funded with pharmacists, and now we are implementing pharmacogenomic testing with a network of pharmacists in BC. Now the second part of the project will be pharmacists and also family doctors. So as we say, this is where we're expecting to be a more transformational way of implementing genomics in the clinic in BC. So yeah, that's basically is really a way to transform and not just to have an incremental change. Now, the other piece that is important for us is that, again, the science, great, it is important to develop all these markers, fund those projects, but we're working more and more in those 4 cross-cutting teams that we see are the barriers and the bottlenecks, and I think they join a lot of what we have discussed here already, and is first education of healthcare providers. We can have, we heard the example in Germany, we can have the most wonderful test, and if clinicians don't know how to use it, our test will have no impact. So we need to be able to educate healthcare providers. Big data, big challenge. The data we have is all in little silos, not just by province, but even inside the province. You see the 6 projects we're funding, they're great, all of them, but each of them will have their data in a different place. So consolidating, aggregating, integrating data is a big challenge. Capacity, so having the biobanks, the sequencing facilities and all that, and access, really goes about all the policies, reimbursement, economic impact, economic cost-benefit analysis, and all that. So aside from funding the research, we are working on those 4 cross-cutting teams to ensure the advancement of clinical implementation. And I think with that, maybe we can answer questions. Thank you. If we have time.
Yeah, we have time. Okay. So we have time for a couple of questions. If someone? I get a bit confused because you talk about BC.
Yeah.
So how should we interpret that? Do you work together in Canada, or do you actually see this as a BC project, or?
Oh, we work together, but as I say, it's an interesting situation because when there are these large-scale competitions and funding initiatives, we compete because each province wants to get a little bit of the funding. But we are developing infrastructure together, we have the sequencing centers together, and we work in close collaboration with Etienne and the CIHR. So
within the competition, the regions or the provinces, the regional center will compete, but the overarching Genome Canada and CIHR, we are not competing at all. We're just setting the landscape for them after that to apply. And when we are looking at the strategic orientation overall across Canada, we are trying to work with all the centers and after that to build on what can be done on regional level and create actually some interesting research opportunities, because each province might decide to have a little flavor a little bit different to an implementation or the way they do it, and after that you can compare in a context that is quite similar because we're in the same country.
Yeah, and the other thing is that, those projects that we're funding most of them include at least 3, sometimes 4 provinces and 4 regions. So it's not just all projects I presented that were funded in BC are not just from BC. Most of them are in collaboration with other provinces.
So who is in charge of, like say, biobanks and so on? Is that at the federal level or a provincial level?
The biobanks will be...
provincial.
It's more provincial or projects-based. So each project will be, and again, it can be multiple provinces getting together, but not necessarily managed by the federal level.
And some provinces like Quebec and BC now are developing some registries, and they're working together to have a more centralized way of, a catalog of the different biobanks, because as Etienne say, a lot of the projects will develop their biobank, and then what we need is to build that catalog or database of registered biobanks.
Hi, I'm Daryl Pritchard with the Personalized Medicine Coalition in Washington, D.C. Thanks, terrific presentation. I like the way that you set it up, that there's a number of different competing groups and different programs within the country, but as you mentioned, the key for all personalized medicine will be integrating all of that data. So what efforts are going on in Canada to allow for the interoperability of data that's collected between these disparate programs?
I would say that the biggest driver for that, or the easiest way to bring Canadian provinces together, is to go at the international level. And this is our main reason for, one of the main reasons for us, or the main advantage as we see in collaborating with, especially Europe, because many of our healthcare systems are really compatible, either through organizations like here, ICPerMed, setting up priorities and everything. And in terms of data sharing harmonizations, we've just recently got the result from the data flagship program that we co-led with the European Commission, that we co-developed with the European Commission, which was a very interesting success. So these are the type of initiatives that we're doing, and also being part of, again, things like the Global Alliance for Genomics and Health, and I think that we're hitting above our weight there in terms of the representations of our researchers in various committees and the role that they are playing in developing the tools and the approaches. But I'm biased.
Yeah, and the other initiative that we have that is more local to Canada is called the Digital Supercluster. So Canada is funding now a series of superclusters, and one that is the digital technology supercluster is going to be all about data, and hopefully we'll develop that framework and platform to start sharing more the data. But through CIHR locally again and Genome Canada, we have series of workshops and more to discuss policy, to discuss reimbursement at a pan-Canadian level, not just the provinces.
Yeah, but the one key feature to keep in mind when we're talking about that is that we're on the boundary between research and clinical care. And research, we can do that at the federal level, but clinical care is really a provincial jurisdiction that is really highly valued by the province. So yeah, that's where.
And that's why we say that really the power of that genomic enterprise in the model is that we have this very strong presence in the province where the clinical care is being implemented. And we have this dialogue with the ministries in each of the provinces. So, yeah.
Thank you, Etienne and Catalina.
Thank you. Thank you.